Alright guys, today we're going to go ahead and do a quick video on the pharmacotherapy of headache. There are different types of headaches and we treat different types of headaches differently. Tension headaches, which you guys see right here, are typically characterized by a bilateral band of pain around the head. These headaches are usually associated with stress, and the pain is a kind of a dull, persistent pressure tightening type pain. They're more common in females and again are associated with stress, hence that tension. We treat tension headaches with analgesics. Analgesics like NSAIDs, right, like naproxen, acetaminophen, right, APAP is acetaminophen, Tylenol, and aspirin. A lot of these, specifically acetaminophen, aspirin, we have prescription drugs that combine these with other agents. So we have, there are agents that combine these with caffeine, like Excedrin is an over-the-counter version that combines it with caffeine. And then there are prescription versions that combine these with butalbital. Butalbital is a barbiturate. Is a barbiturate that we talked about when we did hypnotics and sedatives, benzodiazepines. Remember that barbiturates are controlled and they come with a whole host of side effects and dependence is possible. So I would not use, or you should not use, an agent that contains butalbital unless it's necessary. So try, just an NSAID first, or try, aspirin, caffeine first. Make sure that multiple agents are tried before going on to something that has a barbiturate in it, or that has butalbital in it. Also, anything with butalbital, it's important to make sure that the patient is using it less than 3 days a month. Okay, that's the recommended uses, less than 3 days a month. If the butalbital is used frequently or used in high doses, then patients are going to become dependent on it, and it'll require that they go through a slow taper to get off the drug. So any extended use of the butalbital requires a slow taper to get off. Otherwise, there are severe withdrawal symptoms, relatively dangerous withdrawal symptoms, as well as an increased incidence of rebound migraines that occur as the person's coming off of the medication. So again, that's not first line. The butalbital would not be a first line therapy. Cluster headaches are kind of odd headaches in that when you look at the characteristics, they're different than kind of your typical migraine headache. One of the major characteristics that's different is that cluster headaches are more common in males. Most other types of headaches are much more common in females. So migraines, for example, are 3 times more common in females than males. So cluster headaches are the headaches that are more common in men. Also kind of odd is that their onset is typically during sleep, and it's a very, very excruciating, sharp pain that the cluster headache is associated with. When we look at cluster headaches, first line abortive treatment, so a first line drug that you use acute when you start to get the headache, you want to take something to stop the headache and make it go away. Agents include triptans. Tryptans are also used for migraines. That includes things like the kind of original and most common is sumatriptan. Sumatriptan is Imitrex. Again, one of the first migraine medicines, modern migraine medicines that we've had. We can use triptans for cluster headaches as well as inhalation of 100% oxygen. Again, both are first line options to try and abort the cluster headache once it's started. Then finally, we have migraines. And when we look at migraines again are about 3 times more likely in females than in males. Onset's rather variable. The pain is typically unilateral, so just on one side of the head, and it tends to be a pulsing, throbbing pain. Now, when we look at migraines, migraines can be classified into migraines that have an aura and then migraines without an aura. A migraine with an aura is this, like the patient gets this kind of these weird signs and signals that the migraine's about to happen. It doesn't start with a headache. It starts with the aura. The most common symptoms of an aura are visual, so like flashes of light, for example. But visual disturbances, there can be motor disturbances, speech disturbances, but all of these types of just kind of these odd sensations that the person gets right before the actual pain of the headache happens. Most patients don't have an aura, but about 15% of patients will experience an aura before a migraine. Now we're going to talk in a lot more detail about migraines themselves and the treatment of migraines. Again, I mentioned that women are 3 times as likely to be experiencing a migraine headache than men are. Most patients do not have the migraine with an aura. Again, migraine with aura is only about 15% of patients. Now, when we look at the aura, again, the most common prodromal symptom that we'll see is going to be the visual disturbances, and that will occur about a half an hour before the actual headache occurs. If a patient experiences an aura before a headache, that right there is enough for a diagnosis of a migraine because it's not associated with other types of headaches. When we look at the physiology of migraine headaches, it's different in patients that have an aura versus those that don't. The headache part's the same, but in patients who experience an aura before the migraine, we see that there's a depression of neuronal activity, so a decrease of neuronal activity and vasoconstriction that occurs in the very posterior most parts of the cerebral hemisphere. And then that slowly spreads. Because of vasoconstriction, right, because the vessels tighten up, there's not enough blood flow. So there's hypoperfusion to that part of the cerebral cortex. And that hypoperfusion, again, slowly spreads up over the cerebral cortex as the aura progresses. This alteration in blood flow or hypoperfusion is what ultimately leads to the functional changes or the symptoms that the person experiences during the aura. This hypoperfusion in the cortex does not occur in migraines without an aura. Okay, so this first part here is just kind of what's happening leading up to the actual migraine or the actual headache rather. Now the headache itself, the headache pain of all migraines progresses the same. Okay, so once you get past the aura and into the headache, it's the same, whether it's just a normal migraine or a migraine with an aura. The actual headache pain itself is associated with both extracranial and intracranial arterial vasodilation. Okay, so you'll notice the change in blood flow here. At first, there's vasoconstriction, and then those vessels open up and the blood rushes in, and that's when that headache occurs. Also, in addition to this arterial vasodilation, there's also a release of a lot of different neuroactive compounds. And we know that the release of these neuroactive compounds has something to do with the pain that happens during a headache. We don't really understand all of the physiology perfectly, but we know that there's, along with this dilation, there's a release of substance P, neurokinin A, as well as calcitonin gene-related peptide, or CGRP. Now, we target both of these with therapies. We have therapies that will prevent this dilation, that will cause vasoconstriction. And we also have therapies that will block. For example, we've got drugs that are calcitonin gene-related peptide antagonists that will block these neuroactive substances. Now, when we talk about treating migraines, one of the important things to acknowledge is that the patient has a really big responsibility in one, understanding their specific migraine, and in making lifestyle changes that help them to avoid triggers. So trigger avoidance is going to be key. And different patients have different triggers. Caffeine could be a trigger, alcohol could be a trigger, lack of sleep, stress. There are numerous different types of things, certain kinds of foods that can trigger migraines. So the person needs to identify, the patient needs to be able to identify what their actual triggers are. And that can be a process. That's not always easy to do. What we typically do is recommend that patients keep a headache diary. In which they, keep track of their daily activities. What did I eat today? How much sleep did I get last night? How much caffeine have I had? And when they have a migraine, you take note of it, and then they can go back and you can work through them with this diary and see, okay, what trends do we see? What kind of things happen, every time or most times before you get a headache? Or in women, they're so much more common in women. Frequently, you can correlate the migraine to specific times of the uterine cycle, right? And hormonal changes that are occurring, possibly other medications. So it's really important to try and figure out what triggers the migraines, if anything, so that they can be then avoided. And again, the patient has a really big responsibility in this, and it's challenging. So they need to be patient and understand how important this role is. Then when we start to talk about the actual pharmacologic treatment of migraine headaches, we can separate treatment into symptomatic treatment and prophylactic therapy. Symptomatic treatment is when the person starts to get a migraine or experience an aura, and they take the meds right then to try and either prevent it, right, to stop the development of the migraine, or to lessen it and decrease the severity. Prophylactic therapy is therapy that's taken consistently to try and decrease the number of migraines that a patient has. And we'll talk through both of these strategies briefly. So we'll start with symptomatic treatment. Again, symptomatic treatment is an acute treatment. When the person either first starts to recognize that they're going to get a migraine, they take something. Recommendations as far as symptomatic treatment: very important is to use whatever the abortive agent is quickly, to use it early. Right away when the person thinks they're getting a migraine, they take the prophylactic therapy. The earlier the drug is taken, the better it's going to work. And there are numerous studies that show this. Also, we need to caution patients, and we need to exercise caution regarding overuse headaches. What an overuse headache is so say somebody is not on prophylactic therapy and they just use, symptomatic treatment, and say they're getting migraine headaches, twice a week, every week, and they're constantly having to take this abortive therapy. That in itself, the overuse of the abortive migraine therapy can induce a overuse headache. And overuse headaches are hard to treat because our abortive medicine is what's actually leading to them. So we want to avoid this. And the thing that we do here is we closely monitor how frequently patients are having to use their medication. And if they're having to use their abortive medication or their acute migraine medication frequently, then we need to consider prophylactic therapy. So consider prophylaxis if the patient is experiencing frequent migraines. Now, then when we actually look at the drugs that we use for acute migraine treatment, we can separate the drugs into non-specific medications and then migraine-specific drugs that are developed and meant to just specifically treat migraines or headaches. So non-specific drugs include analgesics, These are mostly over-the-counter analgesics, and we use these for mild to moderate migraines. So this would include things like NSAIDs, right, like naproxen. Also antiemetics. A lot of migraines are associated with nausea and vomiting. So when we're controlling the pain of the headache, we also need to control the vomiting that comes along with it. So different things that can be used as antiemetics for migraine headaches include prochlorperazine, and metoclopramide. Both of these work at the dopamine receptor. So when these are used in like in an emergent setting, if you have a patient who's coming into the ER with a really severe migraine headache and the Imitrex that they take at home didn't work, and when they come in, you typically will give, a good dose of an IV medication for the migraine itself, but then also give an antiemetic IV. Now, when we're giving metoclopramide or prochlorperazine via IV, we frequently will also give diphenhydramine. Along with it, and that helps to decrease some of the dystonias and some of the movement adverse drug effects that they can experience right away with that IV, metoclopramide. So analgesics like NSAIDs and antiemetics for mild to moderate migraines. Now, for more severe migraines, we use migraine-specific drugs. That includes Tryptans and Ergot alkaloids, which we'll talk about in a moment. You'll notice I did not mention opioids. Opioids are highly overused, especially in the emergency room for migraine headaches. Opioids should be reserved for rescue meds when other treatments for severe migraine are not successful. So when a patient comes into the emergency room with a severe headache or a severe migraine, the first choice should not be to be giving them an opioid. Again, these are really highly overused in the emergency department. Recommendations say to give a Tryptan IV and or subcutaneous a subcutaneous Tryptan, and to give an IV antiemetic. And the combination of those agents is first line therapy in an emergent severe situation. It is not an opioid. Opioids should only be used when everything else has already failed. All right, so we'll talk a little bit more in depth about the drugs that we use for symptomatic treatment, starting with Tryptans, which are our first line drugs for moderate to severe migraine headaches. We call them Tryptans because all of the drugs end in tryptan. Sumatriptan, again, was the prototype drug. That's the generic for Imitrex. Zomatriptan, Frovatriptan, Almotriptan. There are a few more drugs that I didn't list down here, but they're really easy to pick out because they all end in tryptan. Hence, we call them the Tryptans. When we look at the Tryptans, the way that they work, they are agonists at the serotonin 1 receptors, specifically serotonin 1B and 1D. We think that most of the effect for migraines is at this 1D receptor. Because they're agonists at the serotonin receptors, when they bind to these receptors and stimulate them, that leads to vasoconstriction of the cerebral blood vessels. These specific serotonin receptors are found on the peripheral nerves that innervate the vessels, the intracranial vessels. So those nerves are innervating the vessels. When the tryptans bind to the serotonin receptor, it stimulates the smooth muscle and there's vasoconstriction of those vessels. And remember, that fixes the problem. The problem with migraine headaches was that first there's the vasoconstriction in the back, and then the vessels dilate, and there's that big rush of blood, and that causes the migraine, the pain of the migraine. So vasoconstriction of the cerebral blood vessels prevents that pain of the migraine. The triptans also cause, or they inhibit the release of calcitonin gene-related peptide, which we said was also one of those neuroactive substances that's associated with migraine headaches. We don't understand all of the effects of the migraine medications that well, so there might be other mechanisms that are working too. But this is the main mechanisms that we know right now. The use of the triptans. They are first-line agents for the acute treatment of moderate to severe migraine headaches. Notice this is not mild. For mild migraine headaches, we use NSAIDs, acetaminophen, aspirin, just analgesics. For the acute treatment of moderate to severe migraine headaches, though, we can start to use the triptans. And they are very effective. They abort, like completely stop, or reduce the symptoms of a migraine in about 70% of patients. So those are pretty good numbers. And the triptans are much better tolerated than older agents. In a second, we'll look at the Ergot alkaloids. Those are the older migraine meds that we have, and they are associated with some nausea and some other side effects that make them less desirable than these newer triptans. Now, there is a variable response to individual drugs. What that means is that they're not all created equal for all patients. There aren't head-to-head trials saying, that sumatriptan is always the best agent or that amitriptan is always the best agent. Different triptans work better in different patients. So you could have a patient that you try on sumatriptan, and the patient says, it barely works at all, or it's not helping, or, they're not happy with the response. Then you could try them on frovatriptan, and it could work beautifully. So don't give up after trying one medication. If it's not effective enough, try another one of the triptans. They have different they have different pharmacokinetic profiles. Half-lives are different on them. And there are just slight differences between each of the agents. So go ahead and try a different one, and the patient might respond better to the second agent that you try. If the migraine is complicated by nausea and vomiting, then you should just combine the triptan with an antiemetic agent, right? So like prochlorperazine, for example. Also, there is a combination agent available, sumatriptan plus naproxen, which is an NSAID, is also considered first-line therapy. And the combination of a triptan and an NSAID has shown to be more effective than either agent alone. So that is an option as well. If you've tried a patient on just a triptan and they're not getting as much of a response as you'd like, it is beneficial or likely beneficial to try the combination of both agents, or you could always combine them on your own, because I can assure you that the combination agent is more expensive. So the sumatriptan, which is available generic now, I'm sure you could do the sumatriptan, and the person can buy naproxen and can take them together on their own. And that will be cheaper and also give you the added benefit of taking both drugs together. Triptans are also used for the acute treatment of cluster headaches as well. The mechanism of action amongst all of them is the same. Where the different agents differ is their kinetic profile. All of the triptans are available in oral formulations. There are intranasal formulations of both sumatriptan and zolmitriptan, and then sumatriptan also comes in a subcutaneous formulation as well. The benefit of the parenteral formulations is that they have a much faster onset. So parenteral onset is about 20 minutes, whereas the onset of the oral formulation is about 1 hour at the quickest. So if somebody has a really severe headache in the emergency room, obviously you're going to want something to work very quickly. Hence, giving it subcutaneously is preferable to giving something orally. Also consider if the person is vomiting. Right? If they come in and they're vomiting, giving them something orally is not going to be beneficial. Hence, we give things parenterally frequently in the emergency department. Half-life between the agents varies widely. I just have a couple examples up here to display that. The half-life for sumatriptan is 2 hours, whereas the half-life for frovatriptan is over 24 hours, and that is the longest acting agent, frovatriptan. Now, it is not uncommon for patients to get a recurrent headache about 24 to 48 hours after they've taken the triptan. So for someone to start getting a migraine, to take the triptan, it works. But then 24, 48 hours later, they start to notice that the headache recurs, it comes back. If that happens, it's okay to take another dose. So a second dose can be taken for recurrence, and that typically will abort the headache, and then the patient can, go on until their next episode. Adverse drug effects. I say this first one with kind of a caveat here. So according to your textbook and drug information in the package insert, there is an association with increased blood pressure and possible cardiovascular events. So the recommendation is that if patients have risk factors for coronary artery disease, that you need to perform a cardiac evaluation before using the triptans. Now, I did go on UpToDate and I read a lot of reviews saying that there's no connection between triptans and cardiovascular events, adverse cardiovascular events. So that's one of those things that's kind of rapidly occurring, changing, developing. So I would look more into it if you have a patient who, has possible coronary artery disease, some cardiac risk factors. I would look really closely at that specific patient, do some research on the triptan, and evaluate if you think it's safe in that patient or not. So as far as cardiovascular events go, but just keep a caution in your head with triptans. Common side effects, dizziness and malaise are most common, kind of general side effects. There are a few cautions and caveats with the use of triptans. They should not be used more than 10 days per month, just per recommendations from the drug. Also, they should not be used within 24 hours of the Ergot alkaloids, which are the other migraine medicines that we're going to talk about next, or within other triptans. So patients shouldn't be combining triptans and going back and forth from one to the next. Again, I said that you can give a second dose of the same medication for a recurrent headache, but they should not be flipping around from one agent to the next. Also, do not use with MAOIs, monoamine oxidase inhibitors. They cannot be combined. Also, because of the serotonergic effects. Now, there used to be concern for serotonin syndrome when triptans were combined with SSRIs or SNRIs. However, all of the latest research says that there appears to be, no risk or very, very minimal risk of serotonin syndrome when patients who are on an SSRI or an SNRI have to take a triptan for migraines. This does become important because we do use a SNRI like venlafaxine. We do use that for prophylactic migraine therapy. So you think, okay, if someone's taking this SNRI for prophylaxis and they do have a breakthrough migraine, can they take a triptan for that? Yes, they can. the risk of serotonin syndrome is very, very minimal, and that's not really a concern for us. However, it is a concern with MAOIs. So MAOIs should not be used for prophylaxis for migraines. SNRIs can be used, that's okay. We'll see even TCAs, tricyclic antidepressants like amitriptyline, can be used. Ergot alkaloids are the other agents that we can use for the symptomatic or acute treatment of migraines. The mechanism of action of the ergot alkaloids, like ergotamine and dihydroergotamine, they also are agonists at the serotonin 1D receptor. Because of that, they end up causing vasoconstriction of cerebral blood vessels. Now, ergot alkaloids have really complex effects. We don't understand them very well, which is kind of a theme with migraines, but they bind to various different receptors. We know they bind to serotonin receptors, alpha receptors, dopamine receptors. So there's a lot going on with them. That also means there's a lot going on with adverse drug effects. And because of that, they're not typical first-line agents. Caution, because they can cause significant vasoconstriction beyond the vasoconstriction that occurs with the triptans. Because of this significant peripheral vasoconstriction that can occur, they are contraindicated in patients with angina and peripheral vascular disease. When we look at the two agents on their own, ergotamine, when ergotamine is used, it really has to be taken in the very early stages of a migraine in order to be effective. So for all agents, we really say take it as early as possible, right when you start to notice that you're getting a migraine. But that's especially important with ergotamine. Ergotamine comes in multiple different dosage forms. There are sublingual tablets. And then there are oral and rectal formulations that are available co-formulated with caffeine, which also has a vasoconstrictive effect. When you look at prescribing ergotamine, there are really strict dosage limits. So there are daily limits as well as weekly limits, because it can cause dependence, like physical dependence, and rebound headaches if it's used too much. Dihydroergotamine has an efficacy that's similar to sumatriptan, but because of adverse drug effects with it, we don't use it as frequently. When we look at the dihydroergotamine, its use is limited to very severe cases of migraine that typically don't respond to other agents. It is associated with nausea as a common adverse drug effect, which is problematic because nausea and vomiting very frequently comes along with migraines anyways. But dihydroergotamine comes in both IV and intranasal formulations. So that was acute treatment or symptomatic treatment of migraines. Migraines can be really debilitating for patients, especially if they get them frequently. If it's a migraine once a year, that's something that can be dealt with. But if patients are getting migraines multiple times per month, that really interferes with your living, right? If you can't work, can't take care of your children, can't take care of yourself, it's very, very debilitating. So we also can use prophylaxis. We can give prophylactic therapy, daily therapy to patients to try and decrease the number of migraines that they get. Prophylaxis is indicated if migraines occur 2 or more times per month, and if those migraines are severe or they're complicated by serious neurologic signs like an aura. When we look at treatment options to use for prophylaxis, there's no one prophylactic agent that's best. There are various types of agents that we use. And you really should look at the patient's comorbidities and their specific needs when choosing the specific prophylactic agent. Beta blockers are generally considered the drug of choice for migraine prophylaxis because of their safety and efficacy and just the fact that we've studied them a lot for this purpose. So drug of choice would typically be beta blockers like metoprolol. We use timolol as well as propranolol. There are numerous other recommended agents, though, that are perfectly acceptable to use first line, again, just depending on your specific patient and what their needs are. Anticonvulsants like topiramate or valproate, divalproex. A lot of anticonvulsants are commonly used. SNRIs and TCAs, so SNRIs like venlafaxine, TCAs, amitriptyline is commonly used. And then calcium channel blockers as well, such as, say, verapamil. So there are various different agents that can be used. And again, it really just depends on your specific patient. Couple kind of things to keep in mind. Valproate is contraindicated. It has teratogenic effects. So valproate should not be used in patients, in women of childbearing age, unless there's, they're using protection. They're 100% positive that they are not going to get pregnant because it is teratogenic. So in general, avoid valproate in women of childbearing age. Topiramate. Topiramate is good in patients who are obese because it is associated with like an anorexia and weight loss. So if you have a patient who suffers from migraines and is also obese, and you're trying to choose a first-line agent, well, topiramate would be a good agent in that patient because it helps both issues. Amitriptyline. Amitriptyline causes drowsiness, so amitriptyline would be good in patients who have insomnia. So that would be a good choice if your patient has insomnia as well as migraines. If you have a patient who also suffers from depression, well, venlafaxine would probably be a really good choice in that case, or amitriptyline. But venlafaxine is an SNRI. That could accomplish both. It could treat the depression as well as act as prophylaxis for migraines. So again, there are a lot of different choices. It just kind of depends on your patient. I will mention really quick, there are newer drugs that are called calcitonin gene-related peptide antagonists. So calcitonin gene-related peptide, or CGRP antagonists. And these are newer agents, but they're not recommended as either prophylaxis or acute treatment. They're not recommended as first-line agents right now. There's a lack of studies, a lack of evidence available that shows that these are better. Maybe in the future more will come out that will make these indicated as first line, but right now these are not first line agents. An example is orenumab. These were originally approved for prophylactic therapy, and just right now in like February of this year, there was an agent that was approved for acute treatment as well. But again, they're not indicated as first-line therapy. They can be considered in patients who, can't tolerate any of these other prophylactic meds, or maybe they can't stick with taking a daily medication. maybe you could then consider a CGRP antagonist. These are given monthly or quarterly. So as far as compliance goes, that's nice. But there's just not enough evidence to recommend them as first-line agents yet. All right, guys, that is it for migraines. If you have any questions, go ahead and either comment or email me, and I'll talk to you soon.